topic for today is challenges in medication safety. And we have among us a panelist, Dr. Zarine Khety. She is a member of IPA Maharashtra State Branch. Dr. S. Sriram, professor from Sri Ramakrishna Institute of Paramedical Science. Ms. SaiBala, nursing director, Amrita Hospital, Kochi. Dr. Parvez Ahmed, director, Chandan Hospital, Lucknow. So I welcome you all, and without wasting time, we will move ahead. Since we all know that medication errors occurs when we have a weak medication system or human factors such as fatigue, poor environment condition, or shortage of staff that affects prescribing, transcription, dispensing, administration, and monitoring practice, which can result in severe harm, disability, and even death. So I have some questions to all our panelists. So my first question to Zareen ma'am, can you tell us about what are the medication safety issues in pharmacy as a hospital pharmacy?
I think we are short of time. I would just go into the salient points. We have covered quite a few informative sessions in the past, and most of the points have been covered. The medication safety issues originate from the pharmacy. Basically, because the pharmacy is the hub from where you start taking your medicines. So the main issues which we face, or the challenges which we face at medication and in the pharmacy, would be a procurement of the medication. So pharmacists should be skilled enough to procure the right quality and the right quantity of medication, so that you don't have a disruption in the supply chain, which is eventually a continuum to the patients. Okay. So maintaining a continuity of patient care and patient safety is once again the responsibility of the pharmacist. The second important aspect and the challenge with the pharmacist and the pharmacy faces in terms of medication safety is the quality. Because in India, if you see, there are a lot of brands available, lot of generics available. We do not know the bioavailability. Every pharmacy, small or big, in a rural hospital or in a major five-star hospital, wouldn't be able to trace back the origins, or just they have to bank on the company name and say that, okay, this is a good company, this is a bad company. So I would say that in those terms, every pharmacy or the hospital should chalk out its own policy of evaluating what brands they are going to keep and stock in the pharmacy, in the pharmacy, to be distributed to the patients. So this can avoid any patient harm or any adverse events in the future. Then, because we have seen that such cases do crop up, where you have sourced medicines and you have sourced brands thinking that they are good quality brands, and then you finally the health of the patient is injured. Then next important thing is the storage of medications, which the pharmacist, it's a challenging job basically, because you have a huge stock coming in, and you have to see to it that the storage of the medications is done properly. For example, erythropoietin 2 to 8 degrees, vaccines 2 to 8 degrees, insulins 2 to 8 degrees. So all these things may sound very easy, but to stock them in the right quantity and at the right temperatures is a task, is a challenging task, which every pharmacist must be aware of and be responsible enough. The third most important thing is inventory management, because the return on investments, the pharmacy is also economics for and business for any hospital or any healthcare setup. So a lot of it, the money rolls on the pharmacy, medical consumables, medicines, all these dispensing, distribution. So that cannot be compromised at the cost of patient safety. So the pharmacist has to balance this, and that is again a challenge to the pharmacist. So from the pharmacy, these are the things which originate as issues which can be overcome, which the pharmacist has to develop as skills. And then there is a further role which is added now, because the pharmacy has become, as per the AHRQ, that is the US-based agency for hospital and research and quality on patient safety measures. They have really come up with a lot of innovations. They talk of critical care and patient safety, and they have said emphasize the role of pharmacists in intervention, further
Okay.
intervention. Besides procurement, supply, distribution, storage, which is the main hub of the pharmacy, and the pharmacist has to be skilled to overcome all these to give the right patient to the right drug to the right patient. There's also a one step further process wherein the pharmacist has to become a little more, because the pharmacist is the hub of the is the medicine expert. The pharmacist is the medicine expert, and so the pharmacist has to carry and disseminate this information to the clinical and the paraclinical staff of the hospital or the healthcare setup where the pharmacist is located. So the next best step which the AHRQ has said would be to implement the role of the pharmacist, or to escalate the role of the pharmacist to become sort of informants, drug informants. And further step is like we have done what we had done in our hospitals. I've implemented it in so many hospitals, wherever I have done consultation work, wherever I have done work-wise, that we have incorporated the pharmacist role, or the job, expanded the job profile of the pharmacist. Not necessary that we should have a clinical pharmacist. We have trained the pharmacist to be incorporated in antibiotic stewardship program, so that input regarding medications has to come from the pharmacist to the
Yeah,
others of the
totally
hospital.
agreed, ma'am. Training is very much
Training
important to
is
the
very important.
pharmacist.
So, pharmacist
And
intervention in the infection control committee of the hospital, in the
mm,
PTC committee of the hospital, the pharmacist involvement in multidisciplinary teams. I think in Mumbai, we were the first in Sevi Hospital to start a multidisciplinary team, wherein I had incorporated the pharmacist who would take concurrent rounds with the doctors, together with the other team members, and on the bedside, inform them of drug-drug interactions, multi-drug interactions, therapeutic
okay.
duplications, all these things they used to inform. So what would happen is there's a correction there and then. So the
Yes,
next step,
yes.
and then we would have pharmacists doing ward rounds and checking the files to see the length of why an antibiotic has been given for such a prolonged period, why this infusion was not, why this antibiotic was
Mm,
not given
mm.
as an infusion in this form, how many hours was this infusion given, is meronym given in a 12, meropenem given in a 12-hour infusion, is this drug given as a low, that was the loading dose given, is the surgical prophylaxis
Yeah.
completed. So these are interventions which the pharmacist can be helping and it creates, and we have observed that this offloads a lot of as Madam SaiBala said, a lot of a load from the patient, from the nursing staff is taken over by the pharmacist.
Yes,
Lasa,
same thing. Actually, I would like to know, ma'am, from Dr. Parvez, as a clinician and well administrator, what do he thinks on various issues which are faced by healthcare workers or pharmacists in medication safety
yes,
practice?
thank
Dr.
you.
Parvez, sir.
Yes, madam. Various issues faced by the pharmacist in their healthcare practices, right, madam?
Yes, sir.
So, as a clinicians and from the pharmacy perspective, that number one face which number issue which they face, that non-availability of that brand name. Doctor has advised X medicine on the particular brand, but that brand is not available with the pharmacy, and available with the generic name but not with the particular name. So sometimes some of the pharmacists, smart pharmacists, they counsel the patient. So this is the same thing. You can take it, but sometimes, most of the time, patients are very stringent that they want to take a same kind of brand name.
Mm.
Number one, and number two, that sometimes drugs are not available. So if that hospital is having a local purchase policy and all these things, so they can do that, or sometime they refer the patient to the another pharmacy to for the procurement or for the purchase of that thing. So according to me, this is the number one very very burning or major issues which pharmacists faced in their day-to-day
So,
practices.
sir, how do you have a control on doctors if they prescribe the medicines outside the formulary?
Madam, although any hospital should stringently adhere or practice the drug formulary. So for effective implementation, definitely they have to take the loop, the all clinicians that look, please come forward. We are going to decide this medicines. Kindly suggest it and kindly incorporate in the drug formulary. So it will be for your ease and very, very importantly, it will be for the patient ease. So we have to take inside the loop of the all clinicians and accordingly we have to proceed further.
Very
And
true.
again, we have to ensure that whatever the drugs we have incorporated in our drug formulary, those drugs should be available round the clock inside the
Round the
pharmacy.
clock. Yes.
Yeah,
Yes.
but this is a very difficult phenomenon actually.
Yeah.
Yes, madam.
That is why in our hospital, previous hospital, we had kept an open policy. Doctors can prescribe whatever brands they want. If you do not have, you have to go and talk to the doctor. So again, the pharmacist would do that intervention and
Right.
So
talk
my
to them.
questions to Dr. S. Sriram, sir, for pharmacists, what is the essential medication related responsibility linked to patient safety?
Madam, as a hospital pharmacist or the pharmacists who are working in the hospital, whenever the medication safety issues are there, when a patient is taking a medication, it is the responsibility of the pharmacist to tell them what to do and what not to do. Say, for example, I have seen the patients who are taking this nicotine receptor antagonist in the morning session. If it is taken in the evening, for example, Montelukast, if it is taken in the evening, it gives the full effect. The efficacy is very good. So small informations to be passed on. For example, if levofloxacin is given, tell them that if they walk in the sunlight, they may get some red color spots. Otherwise, they will not. Just like that, a small information to be passed on. Otherwise, they will go on for the red spots. Again, they'll go to a dermatologist where they get some steroids or unnecessary piling up of medications for the patients. Small information passed on.
Yeah, the patient has to be counseled about the medication they are going to take, the basic information which they have to know about their medications.
Yes.
Very truly said, sir. SaiBala ma'am, are you there online?
Yeah, I'm here. Yeah.
Acha. Ma'am, as a nursing director, what do you think that what are the issues faced by nursing staff in medication management and challenges faced during medication administration?
So we've already discussed some of them in the earlier talk that I had mentioned. One is again whatever the earlier speaker has said and what Dr. Sriram has said. This all adds on to our table. Because if the doctor prescribes a particular brand and wants, mostly in IP, it's not a major issue because the insistence is not that much. But when somebody actually has a particular, especially anti-epileptics, certain anti-diabetic drugs and hypertensive drugs, when the patient is on that drug for a long time, they bring it from home. And we have a policy, we need to have a policy of how to accommodate them. If that is not clear, then the nurses have a big problem trying to convince the patient that they have to buy it from our pharmacy, or talking to, otherwise sometimes the patient doesn't disclose the reconciliation if that doesn't happen properly. So what happens is, if the nurse and the pharmacy, the clinical pharmacist, in our hospital, most of the department have a clinical pharmacist, so a lot of reconciliation is already done. So when we did not have them, it was on the nursing, and a lot of times we don't have the time to sit and talk to the patient and understand. And then this is also a challenge where you see in Kerala there's a lot of alternative medicine, especially Ayurveda to patients. So the patient, we need to understand that and maybe get information from the patients to understand there's some kind of an interaction that could happen with that. Then once you are actually getting the prescriptions right, that's another challenge where when the doctors have to rewrite the prescriptions, and sometimes we don't get them to do it on time. Then once the prescriptions are there, sometimes the drugs are not available at the pharmacy at that particular moment. But we do have a policy where the pharmacy can buy and give us if that's not available, the particular drug is not available. We have a window period. So those things are addressed, but then that could be another challenge where, the patient, the drug is needed, but then it's not available. So you need some kind of a system where the pharmacy is alerted and they can go get it for you. Major thing would be counseling of patients, especially during
Yeah.
discharge
And one thing I
processes.
totally agree with you, ma'am. There are many patients who are on Ayurvedic medicines. So my questions to Dr. Parvez is there, in India, there is always an alternative medication therapy, maybe jeopardize patient safety. What is your opinion, sir, on this?
Madam, very, very complex questions you have asked me, and definitely it's very challenging. Let me tell you that in Ayush, like which contains your Ayurveda, Yoga, Naturopathy, Unani, Siddha, and Homeopathy. In fact, Government of India is also trying to promote this Ayurveda and Homeopathic hospital. In many district hospitals, they have created the special wing for Ayurveda and Homeopathy.
Yeah.
And personally, I feel that, and definitely they are also treating the patient and contributing to the community. And especially Ayush role like Ayurveda and homeopathy, according to me, this is my personal perceptions that they are more effective in chronic diseases. For example, diabetes, mellitus, cardiovascular diseases, asthma. I am a pulmonologist, so I have seen that a lot of patients which are getting permanently treatment from me, but they are not getting a satisfactory response due to various drugs. They start that alternative medicine and they are pretty much relieved. Good response. And some of the anxiety disorder, menopause, some of the cancer patients which are struggling post chemotherapy and post surgeries, they are also get benefited. And especially, I also do have an excellent experience with the Ayurveda medicine because I am a pulmonologist. Most of the time, I treat the tuberculosis patient. I start them the anti-tuberculosis drug. As we know that ATT is having a very common side effect, the hepatotoxicity. So they land up into the ATT-induced hepatitis or ATT-induced jaundice. So as a pulmonologist in our allopathy, either I have to stop the drug, I have to modify the drugs.
Yeah.
So those kind of patient, I refer to some of my colleagues who are practicing in Ayurveda, and without compromising and without changing my ATT, they treat them with the Ayurvedic medicines, and they came to me. They continue my ATT also, and at the same
Okay.
time we manage
Yeah.
their jaundice also, and combinedly we are treating the patient. So I think it is the time that we should not criticize any other pathy. Every pathy is having the advantage, disadvantage, and we know our pathy. I cannot commit that about their alternative medicine. I have not studied it. So they also are master expert of their domain. But I think that we, government as well as public people, we should come forward, make a CMEs or discussions, get together, so at least we can understand them and they can understand us better. Thank you.
Yeah, it is upon the patient also, sir. He has to disclose that what he is taking. Otherwise, the
Yes,
main
yes, yes.
consultant won't be able to know.
True,
My
true.
question to Dr. Sriram, sir. Sir, we all agree that an updated and accurate information about a patient's current medication is important. However, there is challenges in implementation. Can you suggest a strategic tool to have a success implementation of medication reconciliation, which leads to medication error and unpleasant events?
Yeah, ultimately, everyone is focus is towards the patient care, isn't it? Whether he's a pharmacist or nurse or physician, whoever it is. So ultimately, when a patient receives medication, when a doctor prescribes him the medication, and ultimately he brings it to the pharmacy and get the prescription. Right? First thing is what I have seen in my setup, the antibiotic misuse. Whenever the antibiotics are prescribed, these antibiotics were not taken for the full course by the patients. And that has to be taken care of very well by the pharmacist because we have got Schedule H, Schedule H1. A lot of schedules have come, but still the purchase of the antibiotics for the entire course is not being done by the patients. The importance of antibiotic resistance need to be informed to the patients. And not only antibiotic resistance, we have got a lot of drugs which they are not supposed to stop in between. For example, when they started taking some anti-cholesterol drug, whenever the cholesterol reduces, they stop taking the drug. They say that no, I've checked my cholesterol level is less, so why should I take? Or they compare with the nearby another neighbor, stating that he was taking the medications, he had this problem, so I may get this problem, so I have stopped it. So
Mm.
patient education should be a continuous process, continuous learning process. And whenever the patient is coming to the doctor, the pharmacist, especially the clinical pharmacist, because in our hospital, I could see the role of the clinical pharmacist played a very vital role, especially in prescription auditing as well as in engaging the patients for their counseling purpose. So they treat whenever the patient feels that there is a person, like the pharmacists build the confidence in patients, seeing that that is the strength in abroad countries. The pharmacists, how they are well respected in abroad countries is because of they are given much importance in the abroad countries, right? Because they know, the patients know that there is someone who can really help us, who can really tell us about, who is really caring about our health. So that confidence has to be built in the patients by the pharmacist. That can be done only through patient counseling. That can be done only by talking to the patients regarding their disease in the past.
Yes, sir. Totally I agree. Communicating with the patient is very much essential. So, Zarine ma'am, what are the parameters highlighted by AHRQ as you were saying in your first session in
Yeah.
terms of medication safety?
So AHRQ is a US-based agency which collects a lot of data and reports and then gives us a critical analysis. And it speaks a lot on patient safety. So one of the prime areas is medication safety. So they have highlighted some areas which should be focused on, like most of our patient population is geriatric, that is greater than 65 years of age. So they have talked about reducing ADEs, that is adverse drug events in older patients, by giving that is one point, by reducing harm by over usage of opioid analgesics and reducing nursing sensitive errors. So nursing sensitive administration errors, I think madam has already elaborated a lot, which we all know about. There are studies which have found and discovered that at least one error, medication error, occurs out of 22 errors in during administration, which is a medication related error by the nursing staff. And most of the nursing staff, the criterias for these errors, I think we all know: work overload and shift overload and communication gaps, and so many other back and forth human fallacies are there. Then reducing ADEs in greater than 65 years of patients. They have come up with a tool or a strategy where they say that all those patients, every hospital should have draw up a list of PIMs. PIM is inappropriate prescription of inappropriate medications. Like for example, if you are giving benzodiazepines, which can probably lead to cognitive impairment in patients who are 65 years and above, because their pharmacodynamic and kinetic ability to assimilate those drugs changes a little bit. So what happens is they may tend to have orthostatic hypotension, falls, extra, etc. So this is again patient harm. So they have advised that you should drop a PIM list. So high risk medications fall in that list. Most of the times it is this drugs like escitalopram, sertraline, bupropion, all these kind of drugs, methotrexate. So these drugs, when they're administered, these kind of lists, if you have handy with you in a hospital setup, and if these are combined with the electronic health record, like Sir said, that we should always have these systems. The CDS system is a clinical decision support system. This has to be linked with the EHR of the patient. And if this will give you precise sort of information about what alternative medicine can be given to that patient instead of, for example, a benzodiazepine, that way. So this is reducing ADEs in patients who are greater than 65 years. Again, polypharmacy is another issue which I just mentioned. Polypharmacy, we know it exists at all outpatient as well as inpatient levels. So in polypharmacy, we have this issue of drug-drug interactions. Every drug by itself can cause an adverse drug event. Every drug. Now, if there are two drugs combined, it can cause a drug interaction and cause an adverse drug event. In case of multiple drugs, like for example, if a patient is being given warfarin and aspirin, and then an amiodarone is added to that, so that will exacerbate the bleeding risk of the patient. If a patient is being given an opioid, and sort of benzodiazepine, it can exacerbate lead to respiratory depression. So these kind of pointers have to be kept in mind by the doctors and the nursing staff, and this has to be brought out by the pharmacist, and that is why the PIMs list together with the CDS, that is the Clinical Decision Support System. We may have it manually. Ideally, the right thing to do would be to have it computerized. So it is computerized clinical decision systems, which should exist in all hospitals if they can afford it. And they have to be linked with the EHR of the patient so that you can have alternatives to be given to such kind of patients. So this is one way you can avoid adverse events in elderly patients. And most of our crowd is elderly patients, like above 60 and 65. Then nursing administration, I would not elaborate much on it. Opioid analgesics usage, we have done a study where we have actually found, and the CDC has documented these kind of studies, so many of them, where they say that actually you should wean off the patient on from opioids as fast as possible. We do not have so much of a problem in India, frankly speaking, which I have seen in the West, where there is a mass abuse of opioid analgesics. But we have a restricted usage. But nevertheless, it is still being used, especially transdermal patches of fentanyl and morphine and all such things. Now, the transdermal patches, if you have ever read, they have a release system. So a 25 milligrams patch will have a release of probably 25 micrograms per hour of the drug. I have seen medication errors being caused because two patches have been placed thinking that it will have more effect, and especially in palliative care patients, rather than, so this creates an overdose of fentanyl.
Yes.
So opioid analgesics over usage and proper usage, it should be emphasized everywhere to avoid patient injury. So these are a few of the points which the AHRQ had brought out in terms of polypharmacy, opioid analgesics, nursing administrative errors, and drawing up PIMs. They have found that barcoding technology introduced at administrative level, when the nursing staff uses it, will reduce nursing errors, and this has been almost to the tune of 18% reduction by drawing up a proper inappropriate medication list, combining it with a clinical decision support system, and then using barcoding technology has reduced medication errors to almost 18%. So that loop is followed from the pharmacy to the nursing and administration to the patient.
Very fast, I will ask SaiBala ma'am to just give the bullet points on the way how to reduce administration error to our nursing who have joined the conference.
Yeah, I think we went through everything in the beginning.
Yeah.
First, your competency has to be leveled up. Second, you need to identify your patient with two identifiers. You need to follow the 5 rights of medication. Whenever in doubt, you please recheck. Don't assume that you know what you're going to give. Never administer any drug which is diluted by somebody else. Make sure all your injectables are labeled, and each drug is labeled at the time of dilution. If you don't know the dilution practices, don't do it. Whenever there is a doubt for any medication, call your physician, confirm what you're supposed to do. Then make sure that the patient doesn't have any medications on their own. They are not taking on their own any medications. And then you need to make sure when you're doing injectables, when you're connecting tubes and lines, make sure that you know which tube goes to where, and all of them are labeled. Have a system of reporting your errors. Have a culture of being transparent and being upfront in admitting if you made a mistake, because that can save a lot of people's lives. A blame-free culture within the nursing, so that we can actually pick up errors and correct our systems. Having a multidisciplinary team and a backup of clinical pharmacists who can help you with dilutions, critical dilutions, like especially for pediatrics and chemotherapy, would be of great help to the nursing to reduce their time and improve work efficiency. And then it's also about handling your knowing what you're going to give. at least the crucial, the high alert medications, especially make sure that somebody senior is with you. Get at least 2 people to sign off, check the calculation so that you don't make any mistakes. So these are some of the things that I can remember offhand. I think reasonably
It's
covered
very
most of.
very informative, ma'am, because the basic things we all need to follow. If we follow the basic policies on the process
Yeah.
which are laid down, everything goes in streamline. So
Yeah, and
fight
then what
rights
happens
and
most
all,
of the
yes.
time is that when you're doing the most important challenge would be for any nurse, especially new nurses, would be that you will be called by different people. So when you're actually in the process of preparing a medication, you leave it in the middle and then
In
go and come
between,
back.
yes.
Yes.
That relates a lot
There are
of errors. So in
chances,
the
yeah.
West, that they have a philosophy, they have a culture of no disturbance times and zones. You have a particular zone where you go in, nobody disturbs you. That's important to be practiced in
Yes,
hospitals if
yes,
possible.
very well said, ma'am. So thank you everyone. Since it was a very short panel discussion, we had short of time, but many things were well highlighted by our panelists, which made things clear for